Welcome to the deep dive. Today, we're zeroing in on something really fundamental for your future as nurses: trauma and stressor-related disorders. We've got Chapter 28 of Davis Advantage for Psychiatric Mental Health Nursing, the 10th edition by Townsend and Morgan, as our guide.
That's right.
Think of this less like just reading a chapter and more like, well, understanding these incredibly common human responses to really tough experiences, stuff you'll definitely encounter.
Absolutely. Our mission here is to pull out the core knowledge you'll need. We're talking pathophysiology,
Yeah.
the how and why these happen, the signs and symptoms, what to actually look for.
And importantly, the nursing side: care, interventions, treatments.
Exactly. Treatments, including the specific medications. And look, some of this gets a bit intricate, the mechanisms behind it all.
Yeah, it can be complex.
So we've actually lined up a special expert to jump in later and help clarify one of those trickier spots.
Great. Okay, let's dive in then. When we say trauma and stress in this clinical way, what are we really talking about? What's the core idea?
Okay, so trauma, fundamentally, it's a profoundly distressing experience, right? Something that just overwhelms a person's ability to cope. It causes this emotional shock and can lead to long-term psychological effects.
Like events where you feel your life's on the line
Yeah.
or someone else's.
Precisely. Or serious injury, sexual violence, that kind of thing.
Mm-hmm.
And stress, well, stress is broader. It's that mental or emotional strain from tough circumstances.
Which is normal to a point.
Right, everyone feels stress.
Mhm.
But when it's chronic or just overwhelming, it can definitely play a part in mental health issues popping up or getting worse.
It's always striking how different people react, even to similar events. Why is that?
That's such a key question. And it leads us straight into trauma-informed care. This is, honestly, it's a perspective all of you need to have.
Okay.
It means recognizing just how widespread trauma is and building a care approach that promotes healing, yes, but crucially, avoids accidentally re-traumatizing people.
So understanding that someone's past trauma really shapes how they experience healthcare now.
Exactly. It's fundamental.
Okay, so with that foundation, let's get into the specific disorders. The DSM-5 lays out a few key ones. Where is the best place to start for nursing students?
Let's begin with post-traumatic stress disorder, PTSD. As the name suggests, it develops after exposure to actual or threatened death, serious injury, or sexual violence.
And that exposure, it can be direct, right? Experiencing it yourself.
Yes, or witnessing it happen to someone else, or even learning about it happening to someone close. And really relevant for some fields, including healthcare sometimes, is repeated exposure to the graphic details.
Okay. And when you're assessing patients, what are those telltale signs? What should jump out at a nurse indicating potential PTSD?
Right. There are symptom clusters to look for. First, intrusion symptoms. These things like unwanted, distressing memories popping up, nightmares about the trauma.
Flashbacks too.
Yes, flashbacks, where the person feels like or even acts like the event is happening right now. It's very real for them.
Wow. Okay, what else?
Second, avoidance. People with PTSD often actively try to steer clear of anything, thoughts, feelings, places, people, even conversations that reminds them of the trauma.
Makes sense. They don't want to re-experience it.
Exactly. Third cluster, negative changes in thoughts and mood. This can look like persistent negative beliefs about themselves, others, the world, feeling detached, numb.
Like they can't feel happy anymore.
Right, an inability to experience positive emotions, or distorted thinking about the trauma's cause, leading to blaming themselves or others unfairly.
Okay, and the last cluster.
That's marked changes in arousal and reactivity. Think irritability, outbursts of anger, maybe reckless or self-destructive behavior, being constantly on edge, hypervigilant.
Like jumpy, easily startled.
Yes, an exaggerated startle response. Difficulty concentrating too, and sleep problems like insomnia. It's a lot.
Definitely. And how long do these symptoms need to stick around for it to be diagnosed as PTSD? That's important, right?
Yeah, crucial. For a PTSD diagnosis, these symptoms have to last for more than 1 month. And critically, they must be causing significant distress or problems in their daily life, work, relationships, just functioning.
Got it. More than a month and impairing function. Now, you mentioned acute stress disorder, ASD. How's that different? Is it something nurses will see too?
Yes, absolutely. Acute stress disorder, or ASD, shares a lot of the same symptoms we just talked about: the intrusion, avoidance, negative mood, arousal.
So similar reactions.
Very similar. The key difference is the timing. With ASD, the symptoms pop up after a trauma, but they last for a shorter period, specifically between 3 days and 1 month after the event.
Ah, so it's a more immediate, shorter-term reaction.
Exactly. And it's really important to recognize ASD because Well, if those symptoms don't resolve within that month, the diagnosis might then change to PTSD. It could be a pathway sometimes.
Okay, that makes sense. Resolves within a month, or potentially evolves. What's the next category we should be aware of?
Let's talk about adjustment disorders. These are different because they come up in response to identifiable stressors that aren't necessarily the life-threatening kind we see in PTSD or ASD.
So more like everyday life stressors, but still really difficult ones.
Precisely. Things like losing a job, a major relationship ending, struggling with school, dealing with a serious illness events that cause significant stress but aren't typically considered traumatic in the same way.
Okay. What are the key features for adjustment disorders then? What should a nurse be looking for?
The main thing is the development of emotional or behavioral symptoms like feeling down, anxious, acting out within 3 months of a specific stressor starting.
Within 3 months.
Yes. And these symptoms have to be clinically significant. That means either the distress is way out of proportion to what you might expect for that stressor, considering culture and context,
Oh.
or the symptoms are causing real problems in their social life,
Yep.
at work, school, other important areas.
And there's a time limit on this one too.
There is. Once the stressor itself ends, or its consequences are over, the symptoms shouldn't linger for more than another 6 months.
Okay. And I think I read there are different types.
Yes, exactly. The subtypes depend on the main symptoms. You can have adjustment disorder with depressed mood, with anxiety, with disturbance of conduct like acting out, rule breaking, or mixed types.
That's helpful. It covers a wider range of reactions to life's challenges. Thinking about why some people develop these disorders after stress or trauma and others don't. What makes someone more vulnerable? What are the predisposing factors?
That's a complex mix. You can think about it in 3 main buckets: the trauma itself, the individual person, and their recovery environment.
Okay, start with the trauma characteristics.
Right. Things like how severe was it? How long did it last? How close was the person to the event? How threatened did they feel? Were they directly involved? Generally, the more intense, prolonged, and direct the trauma, the higher the risk.
Makes sense. And what about the person themselves? What individual factors matter?
A lot matters here. Their baseline psychological strength, you could say their ego strength or resilience. What coping skills do they already have? Do they have pre-existing mental health issues?
Like anxiety or depression already.
Exactly. Also, their age or developmental stage, when it happened. Trauma in childhood can be especially impactful. Their basic temperament, personality style, and, importantly, have they experienced trauma before?
A history of trauma increases vulnerability.
It often does, yes.
And the third bucket, the recovery environment.
Hugely important. This is about what happens after the event. Is there good social support, family, friends, community? What are the cultural beliefs around trauma and seeking help? Is their family situation stable?
Access to resources, too.
Absolutely. Access to mental health care, financial help if needed. A supportive, stable environment can really buffer the negative effects. A lack of it can unfortunately make things worse.
This framework is really useful for understanding risk. Okay, let's pivot to the really practical side for our nursing students. Assessment. When they're meeting patients, what specific signs should set off alarm bells for a potential trauma-related disorder?
Okay, assessment is key. Be alert if patients mention re-experiencing the trauma, those flashbacks or nightmares we talked about. Watch for avoidance. Are they reluctant to talk about certain things? Do they avoid places or activities?
Subtle signs sometimes.
Can be. Also look for signs of hyperarousal, increased anxiety, irritability, maybe they seem jumpy, have trouble sleeping. Really pay attention to their mood. Are they persistently sad, detached? Do they express feelings of intense guilt or shame?
And thinking problems.
Yes. Ask about difficulty concentrating or memory issues. And I can't stress this enough. Always, always assess for suicidal thoughts or self-harm behaviors. It's critical in this population.
Absolutely critical.
Yeah.
Okay, based on that assessment, what kind of nursing diagnoses might you typically see for these patients?
Well, post-trauma syndrome is a common one, capturing that cluster of intrusion, avoidance, and hyperarousal symptoms. If the trauma involved a loss, complicated grieving might be relevant if their grief seems stuck or maladaptive.
And the suicide risk.
Risk for suicide is a high-priority diagnosis you must consider if assessment indicates it. Others might include anxiety, disturbed sleep pattern, impaired memory, maybe disturbed thought processes, depending on the specific symptoms presenting.
And when we're planning care, setting goals, what does improvement look like? What are the outcomes we're aiming for?
Good outcomes would include the patient saying, the flashbacks aren't as bad, or I'm sleeping a bit better. We want to see them starting to use healthy coping strategies, things you'll teach them to manage distress.
Getting back into life more.
Yes, gradually participating more in activities, reconnecting with people they might have pulled away from. A longer-term goal is helping them kind of integrate the trauma experience into their life story so it doesn't dominate everything.
And the absolute priority outcome.
The patient consistently states they have no suicidal intent. That's always number one.
Okay. With those goals, what are the core nursing interventions? What will our listeners actually be doing to help?
The absolute foundation is building safety and trust. You have to establish that therapeutic relationship. Consistency helps having the same nurse assigned when possible, creating a calm, predictable environment, minimizing triggers.
And talking.
Therapeutic communication is vital, encouraging them to express feelings, talk about their experience, but in a supportive, non-judgmental way. You're not pushing, you're creating a safe space.
Supporting coping skills, too.
Definitely. Helping them find and use healthy coping mechanisms, maybe journaling, relaxation techniques, connecting them with support groups if appropriate, and education.
Psychoeducation.
Yes, teaching them about trauma, common reactions, coping strategies. It helps normalize their experience, reduces that feeling of what's wrong with me. It empowers them.
That makes so much sense. Now, what about for adjustment disorders? The stressors are different, or the intervention's slightly different too?
The core principles listening, rapport, are the same. But for adjustment disorders, the focus is often more squarely on coping with the current stressor.
So more problem-solving oriented.
Often, yes. Active listening is still key. Understand their view of the stressor. Then you might help them explore problem-solving options, brainstorm solutions, bolster their social support, connecting them with friends, family, maybe community resources.
Helping them set goals.
Exactly. Realistic goals. Breaking down what feels like an overwhelming problem into smaller, manageable steps. And teaching stress reduction skills, deep breathing, mindfulness, things they can use right now to manage the emotional fallout.
Got it. A bit more focused on the here and now stressor. Okay, let's broaden out to the other treatments available beyond direct nursing care. What psychotherapies are effective?
Several evidence-based therapies are really the gold standard here. Cognitive behavioral therapy, CBT, is huge. It helps people identify and challenge those negative thought patterns tied to the trauma or stressor and learn healthier ways of thinking and behaving.
Any specific CBT types?
Yes, stress inoculation therapy, SIT, is often used. It's specifically about teaching coping skills like relaxation, positive self-talk, to manage anxiety before and during stressful situations, kind of like vaccinating against overwhelming stress.
Interesting analogy. What about prolonged exposure therapy, PE? That sounds intense.
It can be, definitely, but it's also one of the most effective PTSD treatments we have. PE involves carefully, gradually exposing the person to trauma-related memories, feelings, and situations they've been avoiding.
How does that work practically?
Usually 4 parts. Education about trauma reactions, breathing skills to manage anxiety during exposure, then imaginal exposure, vividly recounting the trauma memory in session, and in vivo exposure, which is confronting safe but avoided situations in real life.
The goal being to stop avoiding.
To reduce the power of the traumatic memory and the avoidant behaviors, to process the memory so it becomes less distressing, less disruptive.
Okay. Then there's EMDR. We hear that acronym a lot. Eye movement desensitization and reprocessing. What's the idea there?
EMDR is another strongly supported therapy for PTSD. It involves the patient focusing on the trauma memory while doing bilateral stimulation, most famously, following the therapist's fingers side to side with their eyes, but it can also be sounds or taps.
And how does that help? The eye movements.
The exact why is still debated, but the theory is that the bilateral stimulation helps the brain reprocess the traumatic memory, making it less emotionally charged and allowing more adaptive thoughts to connect to it. It helps integrate it differently.
Fascinating. What about group therapy or involving family?
Both can be really valuable. Group therapy offers peer support. Connecting with others who get it can be incredibly validating. Reduces isolation, normalizes reactions, people share coping strategies.
It's family therapy.
That can help address how the trauma has impacted the whole family system. Improve communication, educate family members on how to be supportive without, enabling avoidance or getting overwhelmed themselves.
Right. Okay, finally, let's talk meds. Pharmacotherapy. What medications are commonly used for these disorders?
Okay, medications can definitely help manage symptoms, often alongside therapy. First line for PTSD are usually the SSRIs, selective serotonin reuptake inhibitors. Specifically, sertraline and paroxetine have the strongest evidence.
And what do they help with?
They can help reduce symptoms like depression, anxiety, and those intrusive thoughts. They don't erase the memory, but they can make the associated distress more manageable.
Any others? I think I saw prazosin mentioned.
Yes, prazosin. It's an alpha blocker primarily used for high blood pressure, but it's often prescribed off-label for trauma-related nightmares and PTSD. Seems to help reduce their frequency and intensity for many people.
Interesting. What about anxiety meds, like benzodiazepines?
Benzos, like lorazepam or alprazolam. They can provide quick, short-term relief for severe anxiety or insomnia. However, they need to be used very cautiously.
Why the caution?
Big risk of dependence and withdrawal. Plus, there's some concern they might actually interfere with the emotional processing that needs to happen in therapy for long-term recovery.
Mm.
So generally, short-term, if at all, is the recommendation, not a long-term solution for PTSD.
Really important distinction for nurses to understand short-term relief versus long-term treatment. Okay, so medication is often an adjunct, helping manage symptoms while therapy does the deeper work.
Precisely.
Now, we mentioned trauma-informed care, and you touched on brain changes earlier. To give our listeners a bit more depth on the why behind some symptoms, we've got our special expert, Dr. Ben Carter, a neuroscientist. Welcome, Dr. Carter.
Hello, glad to be here.
Dr. Carter, our audience is nursing students. Could you give us a brief rundown on the neurobiology of hypervigilance and PTSD? What's actually happening in the brain that makes someone constantly feel on edge?
Certainly. It's a fascinating, though distressing process involving key brain areas. Think of the amygdala that's like the brain's alarm system, processing fear and threat. In PTSD, the amygdala often becomes hyperactive.
So the alarm is is just extra sensitive.
Kind of both.
Huh.
It leads to increased sensitivity to potential threats, even ambiguous ones, things that aren't actually dangerous. At the same time, parts of the prefrontal cortex, the area involved in planning, decision-making, and importantly, regulating emotional responses, might show reduced activity.
So the brakes aren't working as well to calm down the alarm?
That's a great way to put it. It's harder to evaluate the threat realistically and dampen that fear response coming from the hyperactive amygdala. On top of that, the body's stress response system, the sympathetic nervous system, the fight-or-flight system, often gets stuck in high gear.
Leading to physical symptoms, too.
Exactly. That's sustained physiological arousal. So you have this combination, an overactive threat detector, weakened emotional brakes, and a body primed for danger. That results in the constant alertness, the jumpiness, the hypervigilance we see clinically in PTSD.
That really helps connect the symptom to what's happening biologically. Thank you so much, Dr. Carter, for breaking that down for us.
My pleasure. Understanding the neurobiology can really inform compassionate care.
Thank you, Dr. Carter. That's incredibly valuable context.
Definitely. Okay, so as we wrap up this deep dive for our future nurses, let's crystallize the key takeaways. What absolutely needs to stick with them as they go into practice?
Okay, number one, know the differences between PTSD, ASD, and adjustment disorders, the triggers, the symptoms, the timing. Be sharp with your assessment skills, recognize those key signs, and always assess for suicide risks.
Foundational nursing care.
Grounded in safety and trust, active listening, supporting coping, psychoeducation, these are your core tools. Know the main treatments: CBT, PE, EMDR, group family therapy, and the common meds: sertraline, paroxetine, prazosin for nightmares, and the cautious use of benzodiazepines.
And the big picture philosophy.
Trauma-informed care, always. Assume trauma could be part of anyone's story. Recognize the signs, integrate that knowledge, and actively work to avoid re-traumatizing people in your care. It applies everywhere.
This has been incredibly thorough. For all of you listening, as you continue your studies and eventually start practicing, keep thinking about how this understanding shapes your approach. How can you bring that trauma-informed lens to every patient interaction, no matter your specialty? Maybe dig deeper into one of the therapies we mentioned, or find ways to learn more about the lived experiences of people who've navigated these challenges. That empathy is powerful. Thank you for joining us for this really important discussion on the deep dive.